Hello, everybody. I'm Thomas Pfammater. I'm doing that grand round about peripheral arterial diseases with you. Feel free to ask me any questions. When it comes to the clinical staging of chronic leg ischemia, there's been that staging by Mr. Fontaine. He was a surgeon in the aftermath of the Second World War in Strasbourg, France, and he published that in the Swiss Surgical Journal. In those days, these journals had still Latin names, as you can see down here, Helvetica Clinica Acta in Basel. Staging system, which is purely clinical, is still widely adopted in Europe. Stage 1 would be a patient without palpable fit pulses, but no subjective symptoms. Then we have the claudicants. Later on, the claudicants have been divided into 2A and 2B. 2A being those who have a free walking distance of about 200 meters, and thereafter they have some pain. And 2B is those who start having pain below 200 meters when they walk on a flat plane. Stage 3, rest pain. And finally, stage 4, those are the patients with toe ulcers or foot ulcers and gangrene. Later on, this staging system has somewhat been modified, introducing non-invasive tests like the ABI and the pulse volume recordings here. It's a bit more complicated, but basically the structure is the same. Asymptomatic, moderate, severe classification. Stage 3 now is called stage 2, 4. In categories is ischemic pain, and 3 is the tissue necrosis, minor and major. On the other hand, we have those stages for the acute limb ischemia. There's like 3 categories, from viable to irreversible. Irreversible meaning whatever you do, you cannot salvage the limb. 2, and this here, as you can see, depends also not just on the pulses, but also the function. You have to look for sensibility, whether it's maintained or not. Here, for example, stage 3, the patient won't feel it anymore, that the foot is ischemic and got paralysis. So these 3 stages, classification systems, are widely used nowadays, and particularly for research, we have to rely on that Rutherford classification, which is obviously more detailed than the older Fontaine classification. The interventional and surgical societies, particularly the surgical societies, did then first in the year 2000 is so-called task classification. Task meaning transatlantic consensus conference, task 1, and then later on, when they modified it in 2007, they called it Inter-Society Consensus for the Management of Peripheral Arterial Disease. That goal of that consensus conference was to divide between appropriate treatment, be it surgical or endovascular, and was essentially based on the anatomical findings of arteriosclerosis. To do that classification, they relied on the evidence-based literature at that point. The problem was that soon after 2005-07, there was quite an extensive development of tools and so on, which made that classification not much adoptable. In task 1, A lesions, for example, they were endovascular, TB endovascular also, interventional, the same. Task C and D were essentially surgical procedure, meaning generally bypasses. As they wanted to do a third update, many surgeons didn't agree. And finally, they just did an adapted that classification, which was limited to aortic, iliac, and femoral-popliteal lesions, and included the infrapopliteal lesion and called it then task 2 modified classification. That was in 2015. Since then, there hasn't been an update of that vascular staging system. I'll give you a few examples. That's a 75-year-old woman with a history of smoking and hypertension who presented with a lung edema, and she had earlier on revascularization, as you can see here, of the abdominal MRA of both iliac artery stenosis by stents. Therefore, we have that artifact here. But those times, maybe they didn't look at the aorta well enough. As you can see here, suprarenally, there's a high-grade stenosis, that's black here, and there is a stenosis of the left renal artery. She presented with this flush edema, which is very difficult, very rare, with that type of stenosis, which is the aortic stenosis and renal stenosis. So there is a pressure drop across the stenosis and malfunction of the renal, and obviously also claudication, which is symmetric, and that by some tests you can miss proximal occlusion. So for these lesions, for example, the task classification of aorto-iliac stenosis, it ends here below the renal artery, so it couldn't be adopted. However, here the stents, this will be a task C lesion, and which they advocate surgical treatment. However, as you have patients with a coral reef stenosis, you can hear here you have beginning infrarenal aneurysm stent here. She's not a good operative candidate at her age of 75 years. The typical treatment for that would be an endarterectomy of the coral reef here. However, we just placed a self-expanding stent here without dilating it too much, and that took care of her symptoms, and the renal function improved. And as you can see here, that's before and after the coronary stenosis between the renal arteries and the SMA. And here you can see the stent. And if you look at the manometry, there is quite a gradient as before between the suprarenal artery and infrarenal artery, the pressure drop of 40 millimeters magnesium, which is quite high. And afterwards, just a gradient of about 10, yes, 80 to 70, around 9 to 10 millimeter mercury. So that type of lesion, for example, would not be included in the task classification. Regarding infrarenal aortic stenosis, there's quite some literature about that, and there's that early study by Taft and Montreal, including lots of patients, and they did primary angioplasty, and if it didn't look good or it was still a pressure gradient, they would stent the lesion. On the other hand, more recently, people have done primary stenting, meaning they immediately place the stent without ballooning it, and after stent placement, the ballooning. You can see here, 3 years patented, there's not a big difference between that group where they did provisional stenting and those who did primary stenting. So that's the result at 3 years. for endovascular treatment, around 80%. That's not too bad. That's a 61-year-old male patient, smoker. And you can see here he has a 5 dural recurrent hydrothorax that's related to his liver cirrhosis class B. If we follow the aorta, then here infrarenally there's a mural thrombus which further down completely occludes the aorta. And you can see these large gastric arteries, it's a so-called Winslow collateral pathway. They retrogradely contrast again the internal and those external iliac arteries. Both common iliac arteries are also thrombosed. That would be also type D lesion, according to TAF. However, due to the comorbidities, it is a bad candidate for surgical replacement. So that's the angio. After having crossed the lesion, you see here the terminal aorta is occluded. Collaterals reconstitute the external and internal arteries, about lumbar artery here, for example, across lumbar arteries. And stenting was performed. Here you can see both stents, just bare stents, and then stenting also of the external iliac artery, achieving hereby a quite good and graphic clinical result. So if we look at those long-term data regarding kissing stenting of aortoiliac stenosis, what we have to keep in mind that of the initial patient population, they included a total of 47 patients. 9 of them had, like our patients, like occluded aortoiliac segments. 5 years after, there is a survival rate of about half of the patients. So these patients have generally a bad prognosis, but looking at the patency, secondary patency, that means they had to do re-angioplasty, but basically the arteries remained open, is quite high, and it's in 90%. The study actually was done to look at determinants in terms of the geometry of the stent, whether that might cause those stenosis. And actually they found that, for example, if the stents were undersized, if they're not really abutting the wall of the aorta, they had a high rate of stenosis. On the other hand, if that patient like type D, those 9 patients, that was also putting them at risk of having 3 occlusions. Overall, with those stenting in class C and D patient, primary patency, that's the initial patency, post-interventional is between 60 and 93%, while the secondary patency rate, that means when there is restenosis, you reballoon it, and so you can re-achieve patency is up to 100%. So that stenting technique, which first had been adopted by Julio Palmas in 91, is not that bad and is obviously less expensive than what has lately been propagated by a vascular surgeon, essentially. That's the so-called CRAP technique, covered endovascular reconstruction of aortic bifurcation. In that technique, first the balloon expandable stent graft is placed here and funneled down, as you can see here, and then from bilateral axis, femoral axis, some stent grafts are placed, and with that intention, they thought to improve the geometrical flow characteristics, and on the other hand, reduce the re-stenosis rate from those plaques. And you can see here that a summary series here review analysis of all those studies. It published last year. Primary patency rate is about 5 to 10% better, as just with bare kissing stenting. However, over time, it decreases a bit. You see, after 2 years, it's 84%. However, secondary patency is achievable almost 100% by repeated intervention. That means that these people will have to be followed up about once or twice per year to keep those good long-term results. Now let's move back to the femoral popliteal task 2 classification. So again, task A and B, and many C lesions are endovascular candidates, while the D lesions is a long occlusion of longer than 20 centimeter, or occlusion including the popliteal artery and the infrapopliteal artery, as that will be task D lesions. I'll show you a case that's 6-year-old male without any cardiovascular risks, and he went to the doctor several weeks after he had an acute event of left ischemia. His main complaint is 6 months later that while he plays a lot of golf, he has problems with his medication. So we did an angiogram. That's a direct angiogram. We just inject contrast into the artery. And what can we see here? That's quite important. It's a proximal occlusion here of the femoral profunda artery here, indicating an embolic origin. And that fits to his history. There's no arterial sclerosis all the way down here. And we look at the knee. Again, perfect artery for a 60 years old, but here at the level of the joint, there's an occlusion of the popliteal artery with collaterals here via the sural arteries, and a reconstitution from collaterals of the anterior tibial artery. However, this is the lateral view. The tibiofibular trunk, posterior, and fibular artery are both occluded. So at about 3 months, a colleague tried to reopen that artery and failed, and then finally he was referred to us. Again here, task D lesion, it would be this here, occlusion of all the 3 arteries and stenosis. And here there's one patent but stenotic artery that will be the anterior artery, that will be 3 lesions. That means a primary interventional access, while this here will be surgical. Anyway, that patient refused surgery, and so he was referred to us. I'll show the outcome later on. Here, very good clinical practice guidelines, which have been published last year in circulation. As you can see here, there's plenty of American vascular and surgical societies. Here is the American Interventional Society. And so many slides I will show are from that paper, which I would really recommend. This, for example, that patient we had now kind of fits into the slides, and sometimes not that easy to make the difference between acute limb ischemia and chronic limb ischemia. Any acute one, like the patient we have, eventually will turn to chronic stage. And so some of them, if they're well trained, they may have occlusive disease, but they're asymptomatic. You can easily have no claudication with chronic SFA occlusions and collateral via the profunda femoral artery. Obviously, this guy here didn't have that. So sometimes it's not that easy to categorize those patients. So I tried to regionalize the popliteal artery, and I got down here, and as you see here, it's probably been dissected, and the anterior tibial artery is not well seen, as it's filling essentially by collaterals, which are not depicted when you inject your contrast distally. And eventually, we did a retrograde puncture of the dorsal pedal artery here, went all the way up here, and connected the anterior tibial to this artery here, then stented that presumed dissection of the popliteal artery, and you can see here the final result is a single vessel popliteal outflow here going all the way down to the foot, which dorsal pedal artery has been dilated also, and you can see here quite a good result. So the arcuate artery, you got the reperfusion also of the plantar artery. So if we look at the risk factors for peripheral arterial disease, at least in our society, the older age becomes quite important. We have many patients now who are in their 80s and have no actually cardiovascular risk factors. They never smoke, they have no diabetes. Some of them will be hypertense, obviously. But so this traditional risk factors, I think, will have to be kind of modified and change over the lifespan of the person. And obviously, you have these more social and economic risk factors, depending on where you're living and how your health system is. You're more at risk of getting an amputation or not. Diabetic foot syndrome. There's an example, for example, a 77-year-old male who has that ulcer here and that ischemic foot. And by MR, we could also see that the first metatarsal bone was infected. In Switzerland, we would classify that as complicated stage 2. Some people would say then, well, that's stage 3 or 4. So you can do whatever you want. Patient had renal insufficiency, and angio shows that there's a tapering off of all the 3 arteries down here. But if you go further, you see that from collaterals, the dorsal pedal artery here is opacified retrogradely, antegradely, sorry. There's no opacification of the plantar arteries. And so at this point, again, we go retrogradely up here, and the through technique with our wire and dilate it all the way down. And graphically, you can see here the anterior tibial artery is now going into the dorsal pedal artery. And that's after resection of that infected metatarsal 5 bone and skin covering. So those diabetic feet, I think we can offer them quite some help by endovascular techniques. Another patient here, we spoke about stenotic diseases. That's a dilatation of the aneurysm, popliteal artery, I think about 15 millimeters diameter. We can call them aneurysmatic. The popliteal aneurysm are often isolated. I mean, there's not associated infrarenal aortic aneurysm. However, if you have an aortic aneurysm, the chance of having also popliteal aneurysm is higher. They hardly rupture, but they present either with acute ischemia, thrombosis, or chronic thrombosis, that's atherombolization probably, or arteriosclerosis, including the outflow arteries. Sometimes they cause venous thrombosis, but the presentation is rather different than ruptured aneurysm of the aorta. So we decided, the surgeon wanted to do a bypass on one side. They did the bypass, but it took the gentleman quite a while to heal. So he was more than 2 weeks at hospital. And so they said, okay, let's treat the other one by elective stent grafting. That's what we did here. See here the aneurysm and the flow slows down in the turbulent aneurysm, and opacification of the distal artery is less good. So you have to inject really distally to see the outflow artery. This one good outflow arteries, and place the stent graft. However, the stent graft rethrombosed day 26 after its placement. We did aspiration thrombectomy and put him on an anticoagulation, anti-aggregation with rivaroxaban and clopidogrel, and 22 months. You can see here, as well as the bypass here, as well as the stent graft are patent. In acute thrombosed arteries, they have a high limb loss rate. Here, about in 2005, I think that in my first page I started just, there were pre-close and proglides in those days, so I think that's a great help, a great invention in interventional radiology, that you're not limited so much by anticoagulations and by access sizes. So we placed the suture percutaneously. It's a proglide system. Then put in like 9 to 11 French teeth, cross the thrombosed aneurysm. Distally here, we inject some thrombolytics, about 4 to 5 milligrams of RTPA. Back then, we used 200,000 units of urokinase, and place our stent graft directly into the clot. And so that looks like that. That's the aneurysm here. We advanced here the stent graft and deliver it here, and then angiograph, and then sometimes we do some suction thrombectomy. It's obviously not that easy in that elongated artery, but it's quite a good angiographic results here. And here, that's when you bend the knee just to see what happens. So that's stent graft. You see here, with knee flexion, it's still patent, but it doesn't look that great. So the pre-close technique, that's a series you published a long time ago, 2013, which was initially designed for retrograde femoral accesses, works quite well also in antegrade access, and gives you a lot of additional possibilities to treat this patient, because, as I said, you're not limited by anticoagulation, thrombolytics, and things like that. The first patient here, we did 13 patients in the 5 years, beginning the last decade. It's quite old. We compare them to currently published series from Sweden here. Obviously, that's the whole country. They have way more patients, and they did 27 out of those 170 endovascular, and all the other ones still by surgery. In thrombosis, they did first infusion catheter-directed thrombolysis with a median time of 3 days. So these patients must have not been that acute as ours. Indeed, we had advanced stages of ischemia here. You can see with even 3 patients who were considered stage 3. That's according to the classification by Rutherford. I showed you initially these are non-viable extremities, which generally would be amputated. However, the technique I just presented to you has the advantage of being really fast. I mean, You can still do some thrombolytics, but you don't have to be afraid that clots from the aneurysm wall will further go down by the flow to your feet and occlude the infrapopliteal branches. Anyway, the amputation rate was quite low in our series. It was, well, half of them they are there in Sweden, and the patency rate was also very good. However, patients like the one I showed you before, eventually we did some elective surgical replacement in those days of the stent graft by a bypass, as we thought that they were still at risk of having any rethrombosis. If we look at currently, it's an article, a review made by Chinese colleagues recently. The outcomes of open surgery versus endovascular intervention for thrombotic popliteal artery with acute lower limb ischemia. The endovascular technique, they use different techniques for lysis and so on, outperforms the open surgery technique, which consists by a popliteal bypass or popliteal distal bypass. In different categories, primary patency rate is significantly better endovascular technique. Secondary patency is same. 2 years, primary patency is better, and limb salvage rate is definitely better if those patients are treated by endovascular means. I'd like to finish with this last treatment. We were discussing last week what should we do with the patient, and according green are all those recommendations which are really a strong clinical evidence. So for after revascularization, currently the combination of low dose aspirin with 100 milligrams or so with you may know that Voyager study, which has been published last year, recommendation vascular, which is 2.5 milligram twice per day. That combination had a good long-term result, particularly in terms of other cardiovascular risks like heart infarction and so on. Then the controlling of the risk factors, smoking cessation, exercise training, and so on. Okay, so that's for after equalization, and SAPT means a single treatment, while DABT is double treatment. So the aspirin or clopidogrel are recommended for these PAD patients. I think that was all for today. And is there any questions from my young colleagues in Dar es Salaam? No questions. Okay, then thank you for your attention and goodbye. Oh, there's one question. We're just checking whether there's any questions from
Yeah, I will ask.
Our colleagues.
No, I have a question. Why do we have to use so many classifications to achieve the limb ischemia classification? We have the Fountain, we have the Rutherford, we have the Task, and still other discussions. That's one. But number two, is it rewarding to intervene the limb ischemia? What is the chances that we can salvage the limb?
Well, if we look at we're speaking about acute ischemia or about diabetic feet and so on, there are acute limb ischemia. I think the first thing is we have to do rapidly correct diagnosis and treatment. I mean, that's quite well demonstrated by the data, I think, for acute occlusion, be it embolic or acute and chronic thrombotic occlusion. And I think timing is very important. And if you do, for example, I mean, for many years, it was relying on the local thrombolysis, but local thrombolysis eventually will open that artery, but it's somewhat late. In addition, the longer you wait, particularly in a younger patient with quite some muscles in his calf, you will not go around fasciotomy to decompress the calf. So if you do it immediately, or particularly in young muscular patient, you may be able to avoid fasciotomy. In older patients who have a certain atrophy of the muscles, it's less important. So they tolerate some ischemia better. On the other hand, if you get like an acute and thrombotic occlusion, like elderly people have their stenosis, which eventually thrombosis, they have some collaterals, and it's quite well tolerated, and you can wait, you can assess it, and so on. So that was one part of the question, and the other one was why do we have different classifications? Basically, the classifications don't differ that much, whether it's Fontaine or the Rutherford. The difference is one is purely clinical, as it was published, as all those non-invasive testing methods were not available anymore. But the Rutherford classification is basically about the same. The difference being that you have also the pressure measurements, the ABI, ankle brachial index, for example, and pulse volume recordings. But if you just treat patients and don't want to do any studies to compare different issues, different patient categories, I think you can well do without it. And indeed, if we speak about Fontaine classification, many general practitioners know what you're speaking about. While if you say, well, the patient is Roman 3 class 4, nobody knows what you're speaking about. So I think keep it simple is essential. Thank you.